Uh, Good afternoon, everybody. Thank you for joining. We had a really nice turnout of registered folks for this webinar of over 100 people, so clearly a topic that folks are interested in. This is the Oregon Health Authority EMS Office CMS Ambulance Waiver webinar. And what we'd like to do is make sure that people can hear the audio. So if you would give us a chat box back that you're able to hear audio okay, or if you're having any problems with audio, that would be helpful. A couple housekeeping items. We're going to have everybody on mute, and we will ask that if you have questions that you want us to get to at the end, that you go ahead and enter those in, and when we get to the end of the presentation, we'll answer questions that people submitted in advance, as well as catch all of those that may have come in throughout the presentation. So again, welcome. Thanks for joining. I'm Sean Baird with Woodburn Ambulance and representing the Oregon State Ambulance Association. And we also have...
Hang on, sorry. I muted people. Go for it.
Good afternoon. I'm Krista Cuthbert. I'm with Medics Ambulance. I'm the billing office manager.
Good afternoon. This is Keon Mesgrube. I work at Oregon Health Authority. I am the manager for the non-emergency medical transportation program known as NEMT. Thank you.
And we'd like to recognize Dana Hiddle, the Oregon Health Authority Deputy Medicaid Director, who has helped us in preparation for today's presentation. So let's dive right into the topic today. What we're going to go over are CMS changes relevant specifically to the public health emergency around COVID-19. That would be the expanded list of alternate destinations, patients over paperwork, appeals changes, what's going on with sequestration and Medicare, and touch on telehealth. We are not necessarily going to have every answer for all of these. They are works in progress. Some of the questions that I had already kind of previewed that folks sent in and drafted up responses to yesterday. We've had further guidance, and I'm already revising what my answer would be kind of as we speak. So we have the best information available today, but folks need to recognize that in this quickly changing environment, it may be that tomorrow new guidance comes out, and we will certainly push that forward to the best of our ability. We will be approaching these from two sources of information. One, CMS themselves and the guidance and FAQs that they have issued, and we will make that document available to folks as a handout. And we also, for both myself and Krista, who are involved with the American Ambulance Association, have access to the American Ambulance Association's subject matter experts on CMS and their legal team, and we have a little bit further analysis that's been done through that team that we will be providing to folks on today's webinar. We also understand there are different consultants in the field, and sometimes interpretations of language change. So just letting you know, for today's purposes, the source of information for Krista and I is the AAA and CMS. So let's dive right in. Probably one of the hottest topics that has been floating around in the ambulance world for a long time is alternate destinations. It's long been a goal of many ambulance services around the country to be able to perhaps more appropriately transport folks to someplace other than a hospital ED in certain circumstances. We've worked closely with CMS on this for a long time, so when the public health emergency that we're in right now rose up, this was one of the first things that CMS came to the industry to talk about. We worked with them to establish an appropriate list of alternate destinations, and their advisory that was out on March 29th came out with their hospital without walls terminology, and basically that allows for, as a part of this emergency, this is not a permanent change, this is during the time of the public health emergency, Medicare will allow for payment to transport to alternate destinations as long as it is a part of a local protocol derived under a state authority appropriately put in place to deal with medical conditions, and that they're going to a facility that is appropriately staffed to deal with the medical condition that the patient is being transported to. So that doesn't necessarily mean that a patient has to be a suspected COVID patient going to a alternate destination to deal only with COVID patients, but it does mean that it has to be part of a coordinated effort that starts with those facilities understanding that they would be receiving patients for a certain condition, that they're staffed appropriately for it, that your medical director and your local medical protocol has been approved through your process to transport under those certain circumstances to an alternate facility. Those alternate facilities come in different types. At the very bottom of the list on your slide set there, it says any alternative location determined to be a part of a hospital. That is going to cover your pop-up alternative care sites, for lack of a better term. I think a good example here in Oregon would be the facility that was being established in Salem that many of you may have read about in the press, where they stood up a hospital-like facility using federal stockpile equipment and things. That location, regardless of whether it's to treat COVID patients or to treat other injuries that they want to segregate away, it needs to be, to get paid to transport there, that has to be determined to be a part of a hospital in an official way. So some hospital has to adopt that, and the state has to sanction that adoption of that remote site. Same would be true if someone stood up a tent urgent care in a rural community in far eastern Oregon. For that temporary location to be an approved alternate destination for ambulance, it needs to be affiliated with a hospital. The other items on that list do not have to have that same affiliation. They simply have to be a part of a local protocol and appropriately staffed to receive the patient's medical condition that they're being transported for. So on a technical note, there are some modifiers that would be used in order to accomplish the billing. Krista, do you want to jump in on this one?
Sure. CMS has not changed any modifiers. These are all normal modifiers that have been billed with for years. The only change that has been added, there is a CR modifier, and if we are dealing with those pop-up hospital sites or the alternate hospital sites, we want to do the first two modifiers, residence to hospital, scene to hospital, and then we want to add that CR afterwards. What that does is that gets through the edits for the hospital address, so it tells CMS that yes, this is not a hospital address that's going to show up in your system.
Great, thank you. And another really essential point on these alternate destinations is that the medical necessity requirement has not been waived or modified or changed in any way. so that's always been a fundamental piece about ambulance transport, of course, that you need to meet CMS's definition of medical necessity for it to be a covered benefit for the patient. So Krista, why don't you go ahead and walk through what medical necessity is? I think that's always a good idea for folks, just to remind everyone.
So it's, in layman terms, it's the method of transport. If there was any other way that that patient could get to the hospital, whether it's a car, a taxi cab, a ambulance, then if that would put the patient in danger of making their condition worse, then you can have medical necessity. So there needs to be an accident, anything that could cause more harm to them if they were to go by any of those other transportation modes. Are they bed confined? Bed confined being unable to get up, ambulate, and sit up, all three of those. So that's, is there an accident? All of those would meet medical necessity. I think the biggest thing to remember is if they could go by any other vehicle and not endanger themselves, then we don't have medical necessity.
Great, thank you.
So the next portion is we're going to talk about the patients over paperwork section of their guidance. The first one is they are pausing the prior authorization program. That really does not affect any of us here in Oregon since they have not rolled it out to the country, but they did stop it as of March 1st. The second one is the accelerated or advanced payments. They have released, to make this more accessible to everyone, you are able to request up to 3 months of your Medicare payments to be issued to you from your MAC in one lump sum. The guidance has been given to the MACs that they need to have these reviewed within 7 calendar days. There is few things for eligibility on it. You must have billed Medicare for claims within the last 180 days prior to submitting the request. You cannot be in bankruptcy. You cannot be under active medical review or have program integrity investigations going on, and you cannot have any outstanding delinquent Medicare overpayments. How this works is that like I said, they will issue you a check within 7 calendar days if you're approved. You're able to continue submitting claims. At 120 days after that check has been issued, the MAC will start doing takebacks from any current claims that you are submitting. And so you have between 120 days and 210 days for full repayment to be done. As of late last week, CMS has distributed over $34 billion to providers and suppliers with this program. Later on in our presentation, there is a link to the FAQ section for this on the CMS website. And let's see, the next section, provider enrollments. They're waiving certain things for provider enrollment. They're waiving some of the screening requirements. They're postponing all revalidations actions for the moment, and they are expediting any new or pending applications that have been submitted. Sequestration. They are starting on May 1st and going through December 31st of 2020. They are not deducting the 2%. This is not a free giving us back money. They are going to extend the program out for this time. So I believe it ends in 35. Is that correct, Sean?
That sounds right. Yeah,
Yeah.
it's one more year at the tail end added.
Right, but they're trying to help in the immediate section. And the next part is appeals. So they've authorized the MACs to be able to give extensions to providers for filing. They are waiving requirements for the timeliness on requests that MACs are asking for additional information to adjudicate the appeals. They're also allowing the MACs to adjudicate the appeals, or MACs or OICs, depending on what level you're at, to adjudicate it with incomplete information. They're also allowing incomplete appointment of personal representation, and they are suspending most of the fee-for-service medical reviews during this emergency period. That includes both prepayment and post-payment reviews. They are stopping all requests for additional information during this time. And they are stopping any post-payment or targeted probes or educational reviews that are in process. They're suspending all of those, and they're releasing the claims that they are looking at to be paid. This doesn't mean that they're not going to continue to be looking at things. If they have any inclination that there is potential fraud, there still could be reviews done.
Great. And telehealth is a topic that's come up quite a bit. And this is one of those where it's very much still a work in progress. There is no provision for ambulance service to bill Medicare directly for telehealth, which bleeds into treat and release that I'll talk about when some of the questions that have come in directly. So we will continue to watch that topic. It's being worked very hard by ambulance services all over the country, looking for that as a relief valve when we are being asked to do more on-scene triage and treatment and arranging for alternative types of care from home for folks. And we hope to have better information or better news on that soon. The telehealth rules that have been relaxed so far are related for physicians to be able to have greater access to their patients and even new patients. And there, you may hear of some ambulance services that have been getting paid for telehealth, and that really is if they have a contractual relationship with a physician or other qualified provider to be their eyes on scene and facilitate that telehealth encounter. That ambulance service can then bill the physician for a portion of that physician's payment, but that again is not the ambulance service billing Medicare directly. So in general, the things that have had changes are the alternate destination, the advance payment, appeals, patient signature requirements, etc. Krista, did you want to touch on that?
I was just going to say, so there is not, as of this time, been any guidance to ambulance for the beneficiary signature requirements. We do know that they have lifted that for durable medical equipment, so we're hoping that they will do the same for ambulance. With the American Ambulance Association's looking into this, we are suggesting that for those patients that have been diagnosed or we are practicing the precautions for it, if we put COVID-19 precautions underneath the reason that the patient is unable to sign, and then still follow the crew member signing the receipt at the hospital. But any other type of transport, they have not let up any guidance for.
Yeah. So I think consistent with that and with all of the other areas that we've touched on, our solid recommendation is to continue to comply to the best extent possible with all the long-standing CMS Medicare policies and rules. Only deviate from that if you're under very extenuating circumstances, and adopt a local policy in advance if you think you're going to be stretched to that point. And that will give you your best set of documentation and your best ability to move forward and recover your revenue for those calls from Medicare.
There is one more I do just want to add. Medicare did publish a ICD-10 code for those patients who have been confirmed with COVID-19. The code is U07.1. That was effective April 1st.
Great. Thank you. And a couple of reminders before we get into answering some of the questions that have come in. One is that there are 2 handouts for today's presentation, and you can access those through your control panel under the handouts tab. And the other is I wanted to take an opportunity to recognize Dana Hiddle, who joined us during the presentation. And Dana, by all means, feel free to jump in if there's anything that you would like to comment on as we move forward.
Thank you, Sean. Can you all hear me?
Yes.
Okay, great. I am very technologically challenged, so I will attempt to jump in when needed, but please feel free to ask me any questions you might have as well.
Great. Thank you again for joining. Let's look through some of the questions that have come in. I think we took, the first question was new rules on telehealth. I think we covered that in that so far that does not impact ambulance service. A question on what variances can be addressed by standard practice versus requiring an 1135 waiver. How does the waiver have to be? Dana, perhaps you could just describe for folks what an 1135 waiver is.
Absolutely. So an 1135 waiver is actually something fairly new to Oregon. We haven't had cause very often in the past to use these. More of the southern states and eastern states are using them for disasters specifically related to hurricanes and tornadoes and things like that. So this is a new experience for us, but it essentially allows the state to ask for flexibilities to current practices as it relates to Medicare and Medicaid when a public disaster has been declared by the President of the United States. So we have submitted an 1135 waiver. It was quite voluminous. There were a lot of things in there from a lot of different parties. The Hospital Association added some information. Our public health partners in licensing and certification also added some information, and also long-term services and supports that are operated by Department of Human Services. We just recently, within the last hour, had a call with CMS on the 1135 that we submitted. There are still quite a few things that are left outstanding to be approved that we need to work through with them. And everything that we have is also posted on our website. I'll make sure to get that link sent out to everyone so you can see what we've requested of CMS for flexibilities. Also, the Hospital Association has submitted an 1135 and received approval for flexibilities as well. And we do have that 1135 approval document on our website as well. In terms of what can be addressed by standard practice versus what is requiring an 1135 waiver, it is literally changing by the day. We're getting new flexibilities from CMS through frequently asked questions and guidance that they're releasing. We're also relying fairly heavily on Medicare policy and blanket waivers. So I would say that if you have a question regarding a specific flexibility that you might need in your area as it relates to Medicaid, feel free to reach out to us in Medicaid, either to myself or Keon Meskoob, who is also on the call today, and we can help work through what flexibilities we currently have in place and what can be achieved through standard practice. Or if we also need to request additional flexibilities from CMS, we're willing to do that as well.
Great, thank you. The next question is, will treat and release be paid, or how do we bill for these services? And I'll handle that. I guess on the Medicare side, we covered it a bit in the presentation, that we're still working with CMS to cover treatment on scene for Medicaid, and on the or Medicare, excuse me. And on the Medicaid side, we do have a billing code for an aid call, and we have been working with Dana and her team about how that can best be utilized in the current situation. I don't know if you have anything else you want to add on that, Dana, or?
Actually, great job, Sean. That is exactly what I was going to say. We're currently looking at that particular code and seeing what's available, what we can do to open things up and provide flexibilities.
Great, excellent. Moving on down the list, questions on non-standard or unapproved transport destinations. I think the guidance that we put up there from CMS on alternate destinations is pretty clear cut. It lists the very specific facility types that are covered, and then anything that is not in there must be affiliated with a hospital and be, of course, again, I want to stress that this needs to be part of a locally driven protocol that's in place. Question, does Oregon have any registered ET3 providers? If so, do they have broader discretion, at least on Medicare patients, or does everyone need the same waivers? So for probably everyone on the call knows, but for those who don't, the CMMI, Center for Medicare and Medicaid Innovation, did a demonstration project called ET3 to look at alternative ways of paying for ambulance service to deliver out-of-hospital care. That program does have an Oregon provider who was selected to be a part of it. However, as of just a little bit ago today, all ET3 activity has been suspended for the foreseeable future due to the public health emergency. They just don't have the ability to get that up and off the ground right now. Next question, is there any difference in options for 911 transport providers versus non-emergency transfers? Krista?
I'm assuming this is just in the broadest sense, the question, but all ambulance transports, regardless of if they're dispatched from a 911 center or a non-emergency, are treated the same. So we would need to follow all the same rules. Great.
And all of these are again related specifically to ambulance, not to NEMT or other forms of transportation. Next question, do waivers expand options for first response providers that bill for services? There is no change that has come out in any of the guidance from CMS that changes anything from Medicare being a transport benefit. So I guess the answer to that is nothing to date, no change to date. A question on how do EMTALA waivers affect hospital-based EMS providers? I'll take a quick stab at it, and then maybe Dana or Keon may want to jump in. But my understanding is that the changes that have been opened up in EMTALA allow some flexibility for hospitals in how they conduct their required medical screening exam and how they do some signage to direct people around the facility on site, et cetera. But they do not specifically address any hospital-based ambulance service issues, and I would definitely refer questions specific to EMTALA to the Oregon Hospital Association. Unless Dana, do you have any additional?
I don't. I think you nailed it. Thanks, Sean.
Great. Can you transport directly from home to hospice? This question, Krista, do you want to tackle that one?
Sure. So there's no change. If the patient is at home, if they are already on hospice, then this would be a hospice benefit and you should be billing hospice directly. But during the COVID-19, there's no change from being able to just do home to hospice, other than anytime if you're doing it outside of this, it's a private pay issue. Medicare does not recognize that. The destinations that are approved were on an earlier slide we showed.
Great, thanks. How does this impact my agency that has to transport over 100 miles to our nearest hospital? Well, first of all, I certainly sympathize with the small communities that have these great transport distances and the amazing amount of stress that this is putting on small volunteer services, as well as the capacity of local medical providers in those type of communities that is being so crunched. Unfortunately, there really isn't anything in the program that specifically addresses that situation other than the alternative destination piece, which means that if you're in a community that is that far from a hospital and you're able to pull together the key players in the community, your county, who oversees your county ASA, your agency, your medical director, your hospital, and maybe a local clinic or some clinic that's appropriate, that's somewhere between your community and that 100-mile away hospital. If you can pull those players together and have a conversation about an approved alternate destination from that list on the earlier slide and build it into your protocol for what type of patients you would take to that shorter distance, that would be one way that this could provide you some relief and have that, if they're a Medicare patient, still have that be able to be paid. Patient signatures. Krista, I think you covered that adequately. Couple other questions. May we take non-respiratory patients to alternate locations to offload the ED? Will we be paid for any non-ED transports? Again, under the Medicare guidance that came out, there is no requirement that those alternate destinations have to receive respiratory or COVID coronavirus related patients. So if there's a facility that's appropriate to receive a particular category of patient, as long as they're medically staffed appropriately and equipped appropriately, that can be a covered Medicare service. Last question I have here are what alternate destinations are being allowed, and I think that's on the slide deck that'll be available in the handout section. Did we have any additional questions come in? Is there any billing guidance or ability to bill for intra-facility versus inter-facility transports? There is no guidance right now available on intra-facility, which I think you mean, is there a transport that happens between parts of a campus of a facility or something, as opposed to moving between facilities? I have not seen anything specific on that, other than, yeah, I would say the only exception to that would be like if you did transport to an alternate destination that was part of a hospital, like a temporary treatment tent that was in a location separate from the main campus, and then subsequently did a second transfer from that location to the main hospital, you would there's no specific guidance on that, but I think you would treat that as if it were any other scene call to a hospital. Is that your feeling, Krista?
If you went to an off-campus site that they had deemed as part of their hospital, I would probably treat it as an H to H modifier, since we've already told CMS that is going to be an extension of the hospital.
Yeah. And do private insurance companies follow Medicare guidelines on transport to alternate destinations? Or do we have to differentiate between the different insurance companies? Krista?
At this time, I have heard nothing that the privates are going to follow CMS guidelines on this. I think it might be a little too early for them to have gotten their information out, so I would have to hold on that.
Okay. So it is a compelling question, because I think generally we do see a lot of correlation, but yeah, I think Krista, you're spot on there that it's going to take a little time for that to work through. And there's a question on what about paying for a non-transport fee? That again is one that I think we touched on quite a bit, which we're working with CMS to get in place for Medicare, and as Dana mentioned, they're certainly working at OHA to try to figure that out for Medicaid. And it looks like that's all the questions that have come in online. So I'd just like to thank everybody for joining us today, and give Dana an opportunity if there's anything else that you'd like to add that we might want to close out with.
Thanks, Sean. Actually, yes, there is something I want to say. I just wanted to thank everyone for everything that they're doing on the front lines and putting yourselves at risk every day to take care of these very vulnerable people. We really, really appreciate everything that you're doing. And I know that sometimes the wheels of government turn slowly, but we are doing everything we can here to provide flexibilities and make your jobs easier. So thank you very much again for everything you're doing.
That's great, and thank you too. We in the field certainly appreciate the work that the OHA is doing, and we know that it's 24/7, just like it is running calls for you all as well. Krista, any final thoughts?
No, just this last slide that is up. Noridian has a hotline for COVID-19 questions, and so we have posted that for everyone. And then the web address is for the fact sheet for if anyone's interested to look up the accelerated advance payments.
Great. Well, thank you everyone for joining.
Thank you.
Thank you.